So Kevin, we've talked in the past about shared decision making. We've talked about how this is a decision between the patient and the clinician, between two reasonable alternative pathways with our guidance. And shared decision making should not be CYA. But how about a patient who is demanding, maybe they don't quite reach that level of against medical advice, but yet they're to the point that they really want to go home. They aren't willing to stay for some additional evaluation or observation, and they don't quite reach that level. That's a balance that we need to navigate that can be pretty tough. In this case, we're going to talk about here is a poster child for that. And we'll see there was unfortunately an adverse outcome in this case. So this is a patient by the name of Linda Baker. She is a 67-year-old woman, lives in a large city in the Northeast. And we're going to start off, as we do with a lot of our cases, talking about the patient story first and then the clinician story next. She's active in her synagogue, multiple philanthropic organizations. She and her husband have worked long careers and now are enjoying their retirements with children and grandchildren. Over the previous years, she's had some medical issues. She's been treated once for breast cancer, ovarian cancer, as well as for mets to the brain. But on a cool fall day in October, she's suddenly awoken by severe right flank pain. Tries to reposition herself, falls back to sleep, but the pain persists. She's particularly frustrated because it is Yom Kippur and does not want her plans to be interrupted. She's been fasting since sunset the previous evening. Soon, it becomes clear that the pain is not going to resolve on its own. She has a history of kidney stones, and this feels similar. Her husband drives her to the nearest ED, hopeful that her pain can be controlled and that their plans for the day won't change. So what we're going to give you here on October 12th is the actual documentation from the physician. I'm just going to very briefly read some of it. She arrived in a stretcher. This is on EMS, right? Flank pain since 6 o'clock in the morning. They said it's a sudden onset, so good job documenting the onset of this. Radiation to the right lower abdomen, denies chest pain, shortness of breath, fevers, other things. She said she has chills, but she always has chills. So it's sort of hard to say what to make of that. And I think this is good. That's from the triage nurse. 67-year-old female from the physician, past history they talk about, and she has pain since 6 o'clock that morning. So it very much correlates with the triage note, as opposed to some of our earlier cases. So that at least is a good thing. Her pain started lower abdomen, radiated to the right side, went to her right flank, is 8 out of 10, worse with movement. Tried Tylenol and gas X with no relief. Now, this is not going to be a case of misdiagnosis, because I'm going to tell you right now, and we'll talk about it in a second here, this was a ureteral stone confirmed by CT.
No one is surprised by that, Michael.
No one is surprised by that, no. But this gets into the more interesting part as we go through it, some of these different, what are going to be med legal and most importantly, patient safety issues. So she denies fever, diarrhea, constipation, dysuria, and on the past medical history, you can see quite extensive, but nothing really in there that would make us significantly concerned as far as any infection. You could say, well, is she relative immunosuppressed with a history of cancer? And let's just sort of leave that sort of for one consideration. But I don't think that would really necessarily, in this specific patient, factor in. Her vital signs are fine. She's afebrile, and her urine is tested, and good job for that, because occasionally, not commonly, fortunately, that is missed. But she does have positive nitrite in the urine. Nitrite, and I think of that as being 95% specific for a urinary tract infection.
Agreed.
She also has some abnormalities in her labs. The creatinine 1.7 could be chronic, could be acute. So that's just something that's a little nebulous. Probably was not the thing that really determined the outcome in this case, but another, just something to be aware as far as making that decision. So as we talked about, Kevin, she got a CT scan, and tell us what it showed.
Well, she's got a mild right-sided hydronephrosis secondary to a 3-millimeter calculus. Nobody's worried about that. It's in the mid-ureter. So this is probably going to pass on its own at some point. However, there is moderate associated perinephric fluid.
So when you think about any ureteral stone, and a complicated ureteral stone in a healthy person, sudden onset of pain, I mean, that sort of classic kidney stone dance where you're sort of white-knuckled on the bed, diaphoretic, and aren't laying down for the abdominal
sound like you've been
exam.
there, Michael.
I have not been there as a patient, fortunately, HIPAA disclaimer on myself, but have seen many patients in that same sort of way. And it's that classic sort of presentation, doing that kidney stone shuffle, kidney stone dance, however you might like to call it. I like to call it the ureteral stone shuffle, but anyways, that's just me being
more specific,
more specific, right? Yeah, OCD, I guess, right? But at any rate, you know, and we're going to show some data in just a little bit here on how often these stones pass. But you're exactly right. A 3 millimeter stone should pass. And data on medical expulsive therapy, unless it's 5 millimeters or greater, is not really helpful based on multiple systematic review, meta-analysis type of studies. And so if you have an uncomplicated ureteral stone, sudden onset is probably, or I should say recent onset, is probably not going to be very it's probably not going to be very helpful to check labs. Likely your white count's going to be elevated from the pain and stress demargination. You wouldn't expect to see a change in your creat acutely with this kind of stone. And so my guess is hers, that 1.7 was probably more of a chronic, but maybe being a little more cautious in that kind of patient. Maybe not. Again, that's not the thing that determines. So we're talking a little about the medicine here, and we're going to give more data on the medical part of it after. But I'm going to tell you what happened here first, Kevin, with this patient. So this patient was reassessed, and as you might remember, in her allergy list, and I didn't really specifically key in on it, but she had allergy to a bunch of medications, and that's going to become important with the trial testimony. And I will tell you, and this is pretty exciting, uniquely with cases 14 and 15, we actually have mock trial video that we're going to share with all of us. And so for this case, it was a mock trial that I did at the SUMA Emergency Medicine Residency in Ohio. And we're going to include a link to the whole thing, but as far as part of this program in the video, you're going to have about a 10-minute segment that we insert in here with the opening statement from the plaintiff attorney, so we can see how these things would actually go and what they key in on. And the goal of that, our goal of that, is to say, look, you know, if you're aware of how this might play out later, maybe take some preemptive measures, first with your evaluation, but also with your documentation, maybe to preempt that. And again, quoting you so many times, Kevin, to hopefully avoid a case being filed in the first place.
Absolutely.
So you can see allergies. She's allergic to sulfa. She is allergic to macrobid. She's allergic to levaquin, so quinolones, levofloxacin, doxycycline, and then clarithromycin, which is a macrolide, which you wouldn't use to treat UTIs anyway, obviously. Okay, so long-winded sort of approach to all this. They have the patient who actually had presented, and we can see initially at 10:52 a.m. with pain, confirmed with the triage nurse and with the physician that it started at 6 a.m., so it's 10:52, and the reassessment is at 3 in the afternoon, so quite a long time in the emergency department. But the patient now states she's not allergic to macrobid, case discussed with Dr. Smith, the urologist, and we're going to talk about how you document a consultation in this case and the next one, because those are both very present to what actually happens, who states to start antibiotics, and they will see in the office tomorrow. Patient and family agree. That's good-ish. Renal colic, and the patient is discharged home. So let's talk about some of the medicine first here, Kevin. We have a diagnosis. I mean, clearly, this is not a abdominal aortic aneurysm. This is not some sort of malignancy of bowel perf. I mean, she does have ureterolithiasis confirmed by CT and is consistent with the history.
Well, she does, but that's not all she has.
Okay.
And I think, too, as we talked about before, and we discussed, you got a neurological symptom or chief complaint, you should focus on your neuro exam and maybe decide whether you need neurodiagnostics. Well, here you've got a renal issue. Granted, renal stones infrequently cause renal function problems, but you did do labs and you found a creatinine that's elevated. Please find a former one and say she has a history of hypertension, this is chronic for her. Because if it was normal before and you've got a kidney problem, it's going to be hard later if there is a bad outcome, and most of the time there probably wouldn't be. We've already said you can practice with luck, but that's not the plan. That someone will say, look, there was an indication the kidney was struggling already because of this obstruction, and a jury of lay people might believe that. So make sure that if you find an abnormality, you deal with it, particularly if it's specific to the disease or the organ system we're looking at that has a disease or a problem in it. And I will just say, too, and this may sound a bit cavalier, but I don't really think it is, you know, short term, in an uncomplicated stone, regardless, for the most part, of size or location, most urologists, probably not all, will say they deserve an opportunity to pass it. And you may be surprised. So even, it's a massive stone, it's proximal. You know what? It's a new stone. They're pain-free. There are no abnormalities. There is no sign of infection. If they're pain-free, there's nothing wrong with giving them a chance to see if they can move this thing downstream.
And I totally agree. And my practice pattern is no matter where the stone is, no matter the size of the stone, obviously hydronephrosis, obstructing stones, they're all allowed the opportunity to pass at home. We're going to show some data on that because even large proximal stones, about a quarter of the time, those pass. So that's fantastic. Now, this case, though, specifically, there's something a little bit different. In addition to the elevated creatinine, and this is this nitrite, which should be very specific, over 95% specific for urinary tract infection. So now what we have is a UTI, and I get it that they say mild right-sided hydro, but there is at least some element of obstruction. Yeah.
I love the way we did that in stereo.
Together, right.
Well, what worries me about these cases and why this has been of interest to me as well is a few years back, there was a series of 3 cases that that I participated in developing defense strategies for. All women in their 30s, all of them had stones like this situation. None of them had even abnormal vital signs or anything going on, but they all had abnormalities on the urinalysis. All 3 of them, despite the fact they had no fever, they had no elevation in white count, etc., came back within 24 hours septic. Septic, 2 of them, 4-limb amputations, the other one died. And seemingly so, 24 hours before, with this clinical picture, they looked fine.
So this is obviously not a healthy woman in her 40s.
Right.
And I get it that she's ambulatory and going to Yom Kippur services and fasting, but the fact is that she does have some other comorbidities that would make us slightly concerned. She's got this elevated creatinine, and, you know, good job for consulting with the urologist. But before we actually get into just briefly the antibiotic selection, I want to just sort of put up the documentation of the consult with the urologist. And this is going to be super important because if we're calling a specialist, obviously that means that either we need their help or we need their advice, right? So we might need their help because the patient's going to the cath lab and we don't do interventional cardiology, balloons and stents, right? In the same way, we don't do ureteral stents or nephrostomy tubes. We might need their help, but we also might need their advice and their guidance because, granted, we know a lot about urology and nephrology and cardiology, but arguably less than a nephrologist or cardiologist or urologist, right, in those specific situations.
You're exactly right. In this case, I love it when I read through it because what didn't happen in the other cases I mentioned, they never thought it was important to call the urologist. It's run-of-the-mill kidney stone, so they've got a few white cells or esterase is there, nitrite is present. Any one of those 3 worries me, and those people came back really, really sick. So they called the urologist here, and although I wish they would have documented what they talked about, we've talked about that. At least it's clear they had a conversation and notified them of the presence of possible infection because the urologist said, start antibiotics, which says, I know that there is a potential for infection, and send that person home.
So case discussed with Dr. Smith, urologist, who states to start antibiotics, and we'll see in the office tomorrow. But what we don't know is what Dr. Smith knew about this situation. And later, how will that play out? So I'm going to actually just jump ahead real briefly to how it did play out as far as Dr. Smith's understanding. So this is a examination, and this is the emergency physician who is being examined by the attorney. That says, I'm going to ask you a number of very specific questions about your discussion with Dr. Smith, that's the urologist. I want you to listen to the question to try to answer the question that I ask. This is the attorney talking to the physician, obviously, who likes to be talked to like that. Did you advise Dr. Smith that this was a patient in the emergency department? Answer, yes. Did you advise on your physical exam, you know there's tenderness in the CVA and the costovertebral angle? Answer, I don't recall if I mentioned that. Question, that's my question. Did you advise Dr. Smith of the initial results of the oxygen saturation of 92%? No. Did you advise Dr. Smith that her pulse was 92 beats per minute? And the reason they're talking about that is because the normal heart rate is 60 to 100, but with the sepsis protocols, they use 90. Weird, don't love it. However, that's why they're saying, and they're going to bring up this point. And answer is specifically for that and not the, answer is and her pulse was 92 beats per minute as documented by the nurses, specifically for that and not the reassessment is the way the answer is. Question, did you tell Dr. Smith what the patient's pulse was? Answer, I would have told Dr. Smith the entire day what happened over a 5 period of time. So he's basically saying my usual customary practice is to tell Dr. Smith everything. Honestly, not really believable. Question, I'm asking you specific questions. This is the plaintiff attorney saying, did you advise Dr. Smith that there had been 3 episodes of vomiting prior to the patient coming to the hospital? Answer, yes. Did you advise that the patient had been on morphine and on Zofran? Answer, yes. Did you advise that she had a complaint of chills? That I'm not sure of. Did you advise some of the beta-creatinine? Yes. Of the GFR? No. Dr. Smith is a urologist. Wouldn't a GFR be important? Answer, no. Did you advise the results of your analysis? Yes. Including the protein? Yes. And the nitrates? Yes. And the leukocyte? Yes. And the esterase? Yes. Advise him of the microscopic findings? Yes. That there was a 3 millimeter right ureteral stone? Yes. Anyway, I'm not going to keep reading through it, but you can see what they're doing here. And this is a smart move legally from the plaintiff attorney, because the plaintiff attorney is trying to establish what actually happened and how believable it was during this conversation. And frankly, this guy, this doctor, I can't imagine how he remembers this exact conversation. But you know what would really confirm the veracity of his memory is to have that documented on here. And here's how I do it. There could be many ways, and I want to hear what you have to say.
Sure.
You could say, and what I do is I discuss with the urologist the patient's presentation, the exam findings, and the test findings, including the fact that the patient had a creatinine 1.7, nitrite positive, and that the vital signs were normal, and you could say heart rate of 92 or whatever. That's not that concerning to me. I get it, that over 90. And he agrees that the patient can be started antibiotics and be sent home tomorrow. So now, Kevin, is the biggest question I want to ask you. She's allergic to a bunch of antibiotics, and now she conveniently remembers she's not allergic to nitrofurantoin, to macrobid. However, macrobid is a urinary antiseptic, not a medication that penetrates the renal parenchyma.
So even if she has selected that based on the remaining antibiotics as one that she will accept, it's not an appropriate choice. It's not an appropriate choice. And as far as you know, documenting, going back to the other question as well, what you spoke with the consultant about, I think you can state, I advise the consultant or the urologist or Dr. Smith of the pertinent positives and negatives. And by the way, aware of the creatinine of 1.7, the things that are most important to you. And I notified him of the presence of nitrate and leukocyte esterase, and he said, do this. He directed me to do this. That is a powerful statement. I know that we have knowledge and we can take care of things on our own, but you asked for his opinion. He directed me to do this. Not we agreed to start antibiotics. He directed me to start antibiotics and send the patient home to see the patient tomorrow. And I think if it's reasonable, you can certainly rely on a consultant's guidance, especially if they have different and a higher level of training in the area than you do. In this case, we know what to do here, but a jury will certainly understand that you're not a urologist, where this oftentimes comes to play as a complex neurosurgical situation. You really may not know what the real outcome is supposed to be. Are you allowed to rely on a consultant's guidance? Yes, you are. If you know, because it's within your scope of practice as well, that it's bad guidance, no, you can't. You have to say, well, I'm not sending somebody home when you're giving me guidance that I know is wrong.
So my thought with this case is several as far as the consultant. And I agree with you that we're asking them for their advice. And if we're asking, again, between not shared decision making, but shared decision making, but two reasonable possibilities with their advice, I mean, I think that's great. The problem here is that macrobid, nitrofurantoin, is not an effective medication against a urinary tract infection, which involves the kidney. And that was our concern with the fluid, with the obstruction. The other thing here is that, I get it, she's allergic to a lot of antibiotics, but what about a second or third generation cephalosporin, like cefuroxime, which is Ceftin, because it shouldn't have any interaction with penicillins, and you can argue first generations if they do, if they don't, but certainly second generations, third generations should not, and those are commonly used in patients who have a penicillin allergy, and I use them all the time. As well, something like cefuroxime is only a twice-a-day medicine, which is maybe even better than something like Keflex, which is cephalexin, which is a 3 times a day oftentimes administered that way,
Right.
antibiotics. So giving a first PO dose of Ceftin in the ED and having the patient go home is a very reasonable way to go, and would have been a much better antibiotic selection, and that does play out later. And you could see with that deposition or that trial testimony that I read, with the testimony, let's just put it that way, with the testimony that I read, that they're really trying to establish, how much did this consultant even know? And in the end, it's not totally believable that all this conversation transpired, because there's no way they could have remembered that.
And you have to be worried when you're giving your deposition and trial testimony, especially deposition testimony, when you're saying, basically implying there was a 45-minute conversation with the urologist,
Right.
that if they're ever asked the same question, they're not going to remember that. And I will also just throw one thing out based on this person's request and recollection that she now can take macrobid. I would say, can you now recall that it's okay to take fluoroquinolones? Could you please recall that? But shared decision making, as Michael has eloquently stated today and before, is these are two reasonable options. This is not a negotiation.
Right.
And you cannot allow someone to negotiate or talk you out of sound, good medical practice. Well, I can do this. I'm sorry, that's not on the table. That's not what we're talking about with shared decision making.
Exactly. All right, so let's go ahead and review some of the specifics here for this case. And first of all, consideration of the most serious diagnosis. And honestly, there's not tons of more serious diagnoses that I think of after you have CT confirmation of a ureteral stone. And we're going to put some data on here later. How often when we do a CT for flank pain do we find alternative diagnoses? So that's going to be pretty interesting during our literature review, which we have with each of these cases. But in this specific case, the question of the most serious diagnosis has to be an infected stone.
Right.
And we have not definitively ruled that out. Now, I get it. If we want to give very specific instructions to the patient, we want to make sure we repeat vital signs, that we, maybe even add on something like a lactate level, repeat exam, have that specific discussion with the urologist, have a defined time they're going to see the patient the next day. I mean, maybe that could be reasonable, but the thing is, this is a high-risk patient, and we need to be ultra cautious with this
And the
patient.
thing is, you can add those labs, but when they look good, my experience has been they are good. It's what happens very quickly in the next 24 hours or so. It can be devastating.
Yeah.
And I absolutely do think you have to realize that this is a serious diagnosis, a high-risk diagnosis, where I've seen many people look at this. In a standard person who has those urinalysis or DIP UA findings, it's not concerning. You superimpose that on an obstructive uropathy, that is where this is an entirely different disease.
Yep, absolutely. All right, number 2, picking the correct antibiotic. We've talked about that already, and that macrobid is not a proper antibiotic for pyelonephritis or obviously for infected stones. Reassurance of a normal white blood cell count, and if you're willing to go with the fact that you can have low white blood cell counts with a patient who has sepsis, and we had a case of a patient earlier with that where the repeat was lower. Well, at some point it goes from high to normal to low. I mean, at some point it's within there. So be very cautious with any white blood cell counts that you're basing your clinical decision on.
Right, and if you're searching for infection and considering it but aren't convinced that it exists, I can see, okay, the white count's normal today, so maybe it's not X, Y, or Z. You already have enough to know, again, with an obstruction and signs of infection in the urine, even if it's not classic pyelo, because they don't have fever, et cetera, that the white count is immaterial to me, because this is foreshadowing what is going to happen because you can't clear the infection.
Well, when you think about discharging this patient, we've talked a lot about the patient's understanding of diagnostic uncertainty in the past, but how about putting something like this in your medical decision making and in the discharge instructions? As we've discussed, a patient who has a stone that's obstructing can become septic very quickly. If you have any chills, if you have any fever, if you have any dizziness, confusion, increased pain, like all those different things, if you have those things, return immediately, because realize this disease could progress. In the same way that someone that has a crush injury might be fine at the time and develop compartment syndrome as they go through time with things. So just putting that simple statement on the chart, again, could have been most importantly patient safety, something that would improve that, but also something that would have been important legally. And then as far as the documentation with the consultant, I've already said how I do it. I think there's a lot of different ways to do it. But man, if you are going to rely on them for their advice, of course, their expertise is something too, but if you're going to rely on them for their advice, and it's reasonable advice, at least reflect what their understanding of this patient was. We're seeing the patient in front of us. We're responsible for that patient. They're not seeing the patient in front of us.
And Michael, I'll add on this one too, that you can't take everybody who has 5 white cells in their urine and a stone that looks like it's going to pass and they look great, and you can't admit all these people and do urgent decompression. But I tell you what, that is the question at hand. Antibiotics don't treat an abscess, right?
Correct.
Antibiotics do not treat an infected stone. They have to be decompressed if that's ultimately where this is headed. So in your documentation with the urologist, it's a quick phone call. Hey, here's what they have. Are you okay? Yeah, I'll see him as an outpatient. Do you want urgent decompression? No, I don't. This case is over.
Yeah, and that's the same thing with a skin abscess, wherever you drain the abscess, a peritonsillar abscess, you need to drain the abscess. The antibiotics are not going to penetrate into there, and these things can go south very fast. And surprisingly, ER doctors are way more concerned about these, I've found, than urologists.
That's so true. Yeah.
But when it's more serious, urologists can't be quite concerned about them. And we're going to see also with this trial testimony how that plays out. So the urology, the defense attorney is talking to the patient's husband. Do you remember who discharged your wife that day, the doctor in the ER? Do you remember the doctor's name? No, I don't. Do you remember what time of the day the doctor discharged your wife? Late afternoon. That's correct. It's like 3:47 or so. Do you know if the doctor spoke to the urologist prior to that? And the insinuation was yes. Do you know the sum and substance of the conversation? He said he spoke with Dr. Smith, said for him to call the office and make an appointment for the next day. Do you receive any discharge instructions? Probably. So this, I think, is interesting. Is like, what is a patient's understanding and remembering later, especially after an adverse outcome, and there is one in this case, unfortunately. After that, what do they remember? What do they understand? And this is, I think, sort of an interesting window into that. Okay, so the bounce back, unfortunately, happens. I think we all sort of know that this is not going to end well. The patient leaves with her husband. They pick up the macrodantin, and again, giving the first dose in the ED, maybe that was done here, maybe it wasn't, is always a good idea, I think. Takes the first dose, at least as it says here, but after arriving at home, trouble going up the stairs, falls, landing on her bottom. Her husband helps her up, and she goes to take a bath. 45 minutes later, he goes to check on her, find her eyes open and breathing but unresponsive, calls 911, and she's back now with altered mental status. She's febrile. She gets 3 different types of antibiotics. Urology is consulted. She's taken emergently for ureteral stenting. She's able to be extubated but has respiratory distress, is re-intubated, develops hypotension, septic shock, requires multiple pressures. And unfortunately, at the conclusion of all of this, the decision is made to make her comfort care, and unfortunately, she expires. And we progress now to the legal. So Kevin, just a couple quick thoughts, sort of roll this all, put a bow on this package here for us before we get to the legal part.
Yeah, you've got a run-of-the-mill kidney stone, appears to be like anyone else you see. She's got some comorbidity. She may be challenging from an interpersonal standpoint. She has specific needs. She wants to go home. She has certain antibiotics. She has some good recollection of what antibiotics she's allergic to, and wants to adjust the treatment and management when she doesn't have the medical training to do so. And what's really hiding behind the background, which is most important, is that we have the hint of an infection here. It doesn't rise to the level of classic pyelo, but in the context of an obstruction, it perhaps is more dangerous than that. And you look at the way these go in the course of this, it's fascinating when you read the literature on it. So there's so many organisms that can actually do this, you have to be concerned. And some of them, actually what's interesting, and I like to focus on this as well, look at the pH of the urine. If it's more alkaline, there are urease-producing agents that can actually cause stones. So the infection, actually infectious agent, comes before the stone. There are over 200 species that do this, and they're some of the baddest actors. Pseudomonas, Klebsiella, Proteus, really bad things, and it can really happen. So when you see, this is a fun fact, when you see a staghorn stone, by definition it's an infected stone. They are created by the organism. And also struvite stones are known to do this as well. So I just wanted to throw that in there to give you the full context of what the medical literature says, that just a few white cells or a little bit of esterase or nitrite there and the patient looks good in this context is a serious, serious finding. And so therefore, final bow on this, as you said, wrap it up. For this case, the consultation is important. I'm so glad they called, but there was more opportunity and more they could have documented with respect to the conversation.
Okay, and we're going to see how that plays out in just a little bit here with that plaintiff attorney. So let's sort of move forward here. Accusation, cause of action. I think that's not surprising. Failure to initiate appropriate antibiotic therapy, failure to perform ureteral stenting, and failure to admit the patient at the first ED visit. They asked the physician, what'd you think? Well, the patient and her husband were very impatient and demanding. They were in a rush to leave. So that's true, but I'm going to give you a question that people ask me very frequently. Well, should I document that the patient is demanding? Should I document that the patient is shouting expletives? That was something, and we might have sort of talked about that earlier, but the point is that if the patient is annoying to us and they're yelling expletives at us, maybe putting that on the chart is good for us, but if there is an adverse outcome, all of a sudden it's not going to be an annoying patient. It's going to be a patient who's advocating for their best medical care. And how do we know they were advocating and why they should have been advocating? Because we discharged them and they died soon after. And they gave all their nieces and nephews puppies for Christmas last year. So,
Yes.
I mean, that's how I think that would play out.
Venting in the medical record may make you feel good at the moment.
Yep.
It's not helpful later because you will not look sympathetic to them as a clinician later if you have to revisit this record.
Secondly, they say they recommended giving a dose of IV ceftriaxone in the ED, but the patient refused. Well, if that's the case, and if you feel like it was necessary, AMA. On the other hand, if you don't feel like it was necessary, at least document that interaction.
Right.
The ED physician spoke with the urologist on the phone and appropriate antibiotics. In addition, they say the plaintiff's attorney pointed out to the ED physician that they didn't ask the urologist to come in to see the patient. This was the patient's husband. I'm not going to read through all of it. I'll keep it up there for a second. But they say after she was discharged, she called the urology office, but the urologist wasn't there that day. So the receptionist said to call back the next day to set up an appointment. Boy, it would have been nice if when this physician spoke with the urologist, if they said, look, I'm in the office tomorrow. We don't need to have an appointment on the books. Just have her coming at 11 or 10 or 1, and that way you have a set, very defined timing for follow-up.
Well, you're right, Michael, and you've given global guidance about how to make patients aware and refine their expectations too. Let them know in a time-sensitive follow-up like this. Hey, if something happens, you call and they won't get you. Let us know. Because that happens sometimes in many cases. Oh, I couldn't get in for my fracture follow-up until 3 weeks later. What happened? We thought we had this all lined up for you to be seen in the next 48 hours or whatever it was.
I had a patient who I was on the defense side, pseudotumor cerebri, and it wasn't known that they had that. And they got an MRI, MRA, and it was all normal, as it will be. They didn't do a fundoscopic exam. We talked about that.
Right.
And they said follow up with ophthalmology, and she did a month later after she had become blind.
Right.
So, follow up tomorrow, the next day, and they did that. In this situation is very different. I frequently, just like you're saying, tell patients, look, I want you to follow up in 2 days, whatever. If you can't get in them, you call us and we will help you get that appointment.
Right, exactly.
And it's very easy to offer that because literally no one has ever taken me up on that. So offer those things. It's a good thing. It's a good thing patient safety-wise, most importantly, but it's a good thing satisfaction-wise. So deposition, more information from the patient's husband. And look, in all fairness to him, I mean, that's one thing that he tried to do correctly. Okay, so the physician says, I remember having discussions with the patient, the family regarding how she was feeling. She was feeling better, wanted to go home. I wanted to give her antibiotics and she was in a rush. So they keep talking about that. And obviously that seems, at least what the physician is saying later after they know the outcome, it seems like that influenced their plan of care. But I don't feel that it should have. I feel that in the end, and you've said this in the past, I think you said this on case number 9, the physician should make a decision as far as the recommendation. Look, there might be a secondary recommendation if they don't want to do the first recommendation, but we should have a specific recommendation we give to the patient, and we can factor in those other things. They got to go home and feed the dog. I get it, right? They don't want the IV antibiotics. They want to have PO, and I'm really a PO. If you're going home on PO, you get PO in the ED.
Right.
With that being said, this is something that leaves too much open for chance.
Absolutely, I couldn't agree more.
All right. So what does the doctor remember? They talked about this, but this is how it actually played out during the trial as far as the questioning, a demanding patient. You told me, among other things, she was demanding, she was impatient. Did you document that anywhere in the chart? I did not, he answers. You told me that she wanted to go home to the holidays. Correct. Did you document that in the chart? I did not. Okay, all right. So as far as the antibiotic selection, and I'm not going to read through all of this, if you go to the second part, was the discussion with Dr. Smith done before or after you became aware of the results of the urinalysis? The discussion was after I had the results, and then they say later on that macrobid is used for UTIs, and they agree that it's used for UTIs. And in the end, that does become a point if that's something that's been helpful. Discussion with the consultant, and we read through some of this earlier, so I'm not going to read through this part again. However, suffice to say, now we're talking about the discussion with the urologist 2 or 3 years later, and it would have been really nice if that had been on the chart at the time. Who has ultimate responsibility is going to be our last point before we get to our literature review. Question, whose decision was it to discharge the patient? Answer, and the physician probably can only answer this way. Ultimately, the decision to discharge the patient is my decision. But it's clearly, in this case, it's in consultation with, a specialist. Did you determine that Miss Baker should be discharged in consultation, you're asking? I'm asking, did you decide to discharge her? Answer, it was decided to discharge the patient. They try to hedge on this thing a little bit, but I'm not sure it's the most effective way that they do that. So let's look at the literature here briefly. We teased you a little bit earlier with the fact that we were going to talk about, and this is from a study for the Stone score, which didn't really work, and it's a very weird mnemonic if you're familiar with this one, because none of them would be easily remembered. Like E, for example, is for erythrocytes. I mean, who's going to remember that? You need a mnemonic for the mnemonic, right? But at any rate, how often when we do a CT for flank pain, for what we think is a stone, we talked about earlier, we're not really doing it for rule in stone in a lot of ways. We're doing it to rule out something else. In the same way with the stroke, we're not doing it to rule in the stroke, which of course you wouldn't see with several hours of stroke symptoms. You're doing it to rule out something else like a bleed or maybe even a mass. So in this situation, we see that around 1.5 or 2% of the time, and some other studies actually go up to 3.1%. So 1 in 33, not common, but common enough, right? We're going to find something else. But what do we sometimes find? Diverticulitis, appendicitis, malignancy, but also perforated viscus or abdominal aortic aneurysm. Okay. How likely is a stone to pass based on its size? 1 millimeter, almost 90% of the time. And then if you go up to stones larger than 9 millimeters, about 25% of the time. Location matters also, but all comers, about half the time proximal ureter, obviously that would be less likely the larger that it is. So bottom line, even for proximal stones, give this thing a shot to pass unless there is an ongoing infection or systemic signs of that infection. So just to summarize things that can cause flank pain, I think we saw a lot of that from the Stone score stuff earlier as far as their considerations. Obviously, it could be a muscular strain, ureterolithiasis, right, diverticulitis, a dissection or AAA, pancreatitis zoster, there could be a malignancy, there could be appendicitis. So a lot of different considerations. And actually, before we were doing CTs for stones, and we can date ourselves just a little bit when we were doing IVPs to look for stones.
Yes.
Well, there was a study, that really the first of the bounce-back death studies done by Michael Kiefer. This is in Milwaukee County. And what they found, of the 9 bounce-back deaths that they localized, they found that 3 of those were from AAAs. So absolutely, a abdominal aortic aneurysm can have pain that radiates the flank and can fool us for flank pain. So if you're thinking about that, my advice and my practice is, if I'm concerned about a possibility of a AAA, simply just going to put the ultrasound on the patient. I'll do an ultrasound of the AAA, and that should be 100% or close to that sensitive to pick up AAAs. So Kevin, the question I'm going to ask you, as always, and then we're going to see how this plays out in a few minutes, would you settle?
No, Michael, I would not.
That was so surprising that you said that. So the question really is, was this malpractice? And again, malpractice is not failure to make a correct diagnosis. As well, malpractice is not failing to practice the way the very best emergency physician in the history of the world would practice. This is standard practice, and this is like or similarly trained, or like or similar circumstances. how that person would practice. And was this reasonable? And then interestingly, in this case, causation plays into it, because even if she had been given that dose of IV Rocephin or started on the oral cefuroxime, whatever, second or third generation oral antibiotics, well, she had her adverse event so quickly when she left the ED, probably it wouldn't have had a chance to take effect. And then, like you said very eloquently also,
Thank you, sir,
earlier, is that, you know, if you have an infection in a closed space, non-draining space, spinal epidural abscess, or a infection / abscess proximal to the ureteral obstruction, the ureteral stone, well, antibiotics aren't going to help anyway.
No.
So there's a causation that plays into this also. So why don't we do this here? So Kevin, before we reveal what actually happens in this case, let's see how this will play out in an actual trial with the opening statement by the plaintiff attorney.
I have the distinct privilege of representing the Baker family, but I also have the distinct honor of representing the memory of Ms. Linda Baker. You're going to hear that Linda Baker was a wife, she was a mother, she was a grandmother. She had worked a long life, very hard, and was very looking forward to retirement. She was 67 years old, as was her husband. They had planned to travel, and they started to do that. They were spending their free time, as they always dreamed they could do, with retirement, with their kids and their many grandkids. And unfortunately, her life was cut short at age 67. She died a tragic death in October of 2016. But as tragic as her death was, the way in which she died was even worse. Her body was ravaged with infection due to an infection that Dr. Schur failed to recognize when he had an opportunity to do so when she was in his emergency room. An infection that developed into what you'll hear called sepsis and ultimately septic shock, where her body began to shut down and the blood to her extremities was diminished to the point where she began to lose or was at risk of losing her limbs. And her family at her bedside had to do the most unthinkable thing any family member would have to be asked to do, and that's to take her off life support. And they did just that with all that family at bedside. But the real tragedy is that all of this was preventable. And all of this occurred because Dr. Schur failed to do his job. He failed to do what he's responsible to do in the emergency room as an attending physician. And whether he was too busy, whether he was just inattentive, it doesn't matter because he didn't do his job. And let's talk about the facts. October 12th of 2016, Ms. Baker was sleeping. She awoke with significant lower back pain. She had had kidney stones before, so it wasn't completely new to her, but this was a little different. It was unrelenting and it wouldn't resolve. And she tossed and turned and tried to get through the night. But her husband knew something wasn't right. They needed to get her to the hospital. So in the morning, they did the right thing. They got her to where the help should be, the emergency room. And once she got there, she came under the care of Dr. Schur. Dr. Schur was the attending that day. Dr. Schur had the responsibility to assess her, make a differential diagnosis, make a definitive diagnosis, and arrange for definitive treatment to treat an infection before sending her out that door, which he failed to do. What happened in that emergency room, it was equivalent to a whole assortment of red flags regarding an infected kidney stone that required definitive treatment that Dr. Schur missed. Let's talk about those red flags. As you would expect, she came through triage. The nurses took a history. They noted that she had had a history of cancer. So we know that somebody with cancer, to some extent, may be at increased risk for infection because she's immunocompromised to some extent. But more importantly, they noted that she had chills. Now, here's somebody that presents with a history of a kidney stone. So bad, she got out of bed, and the first thing she did in the morning was get to the emergency room, and she has chills. Ignored by Dr. Schur, not taken into account in determining whether or not this was not just a kidney stone, but an infected kidney stone. They took vital signs, but perhaps most importantly, they only took one set of vital signs on admission. And one of those vital signs was the heart rate, which was 92. And you're going to hear from the expert witnesses that a pulse rate of 92 in somebody who's suspected to have a kidney stone and potentially an infected kidney stone is actually quite concerning, because it's one of several criteria you look to see whether or not maybe that infection is a more serious situation that would move on and develop into a sepsis. They never repeated the vital signs, not once during her stay. Not before she went home. She was allowed to leave without a repeat set. Her oxygen saturation was 92%, certainly borderline normal, if not outright low, never repeating. The physical examination that was done showed tenderness right at the area of the kidney, at what's called the CVA, consistent with a significant, not diagnostic, but consistent with something seriously going on with that kidney, more than a simple kidney stone. They did appropriately some lab work. Now, the lab work included a CBC that included a white blood cell count, which can be elevated in an infection. It was not, but that does not mean that infection has been ruled out. That does not mean that you don't have a problem that amounts to a brewing infection that's going to get worse over the ensuing hours. They also, very importantly, did a urinalysis. The urinalysis showed nitrates and also leukocyte esterase, consistent with an infection in the urine. Now, keep that in mind. So he was armed with information that suggested that the urine they tested was infected. And against that backdrop, he had a CT scan, the right test, good test to do, but he ignored it. He didn't put the pieces together, because that CT scan should have cinched the diagnosis. It showed a 3 millimeter obstructing stone in the mid-ureter, but it also showed uteronephrosis and perinephric fluid. So this was an obstructive stone against a backdrop of urine that appeared to be infected. Game over. That patient does not go home. But what Dr. Schur did, he called a urologist on call, and he arranged for close follow-up. You know what else he did? Between him and the urologist, and by the way, the urologist has given testimony in this case that denies he was given all the information that I just related to you, because between the two of them, they decided to send her home with a prescription of macrobid. Now, you're going to hear from the experts that macrobid doesn't even touch a infection that's in the kidney. A macrobid is something you would give somebody for a simple UTI. What this patient needed, what Linda Baker needed, she needed IV antibiotics. She needed to be under the care of somebody who could put in a stent or some other device that you experts will talk with you about to help drain that urine out of the kidney. Because if you can picture it, this is infected urine that's obstructed, and it's just almost a cesspool gathering there, becoming more infected and then spreading throughout the body. They failed to do what they needed to do. Now, predictably, when she got home, she got worse. She became unresponsive. They brought her back to the hospital. By that point, she was febrile. By that point, she met this criteria, which you hear called Schur's criteria. They immediately started her on broad-spectrum IV antibiotics. They immediately stented the ureter so that kidney could drain, but it was too late. Had Dr. Schur arranged for those interventions when he had Ms. Baker in his emergency room, she'd be alive today. But unfortunately, it was too late. She became hypotensive in the ensuing days. As I mentioned, her limbs began to become ischemic, and the family made that tough decision to take her off life support. Now, Dr. Schur is going to do what a lot of doctors do, and anyone does when they're being accused of something, he starts trying to place blame. You're going to hear, if he's consistent with his deposition testimony, that he'll blame the family. He'll blame the patient's husband. They were in a hurry to go home. They didn't know what allergy she had to antibiotics. He'll blame the urologist. Well, I told him, he's the one who told me what to do. I relied on him. He's blaming everybody but the person who deserves the blame. And the evidence is going to show that that blame rests on his shoulders. That's where that blame rests. If he had done his job, Ms. Baker would be alive today. And as a consequence, at the conclusion of this case, I'm going to ask that you try to right this wrong by giving a monetary award to the Baker family. Thank you for your time.
Kevin, that was fascinating. And I have to say, if I was on the jury, those are some pretty persuasive arguments.
Absolutely. Absolutely.
Okay. All right. So let's find out what actually happened here. About 1 year after the ED visit, the lawsuit was initiated. And 7 years later, the case was closed per court records. And they jointly both filed to discontinue the lawsuit, almost assuredly meaning that they reached a confidential settlement. So for folks who want to watch this entire mock trial from Summa Emergency Medicine Residency, we can see here the plaintiff attorney sitting by themselves on one side. We can see the defense attorney on the left and the volunteer defendant from the emergency department on the other side. And we can see myself in the middle as the judge with the black robe. So
Yes.
You can watch this entire trial. It's about 2 hours and pretty fascinating, and see specifically how trials might play out. Kevin, let's round this up with our 5 take-home points. If a patient is refusing care, I'm not saying this case specifically, most importantly is a medical decision-making note, but used in conjunction with a correctly filled out AMA form.
Absolutely, I agree. Infected stones, it's an entity. Be aware of it, be familiar with it. And the question at hand really is urgent decompression. And so on these, they don't all have to come into the hospital, but I think a phone call to the urologist and asking that question and documenting their answer is really important. And also, as Michael has said so many times, make sure the patient is aware of uncertainty. Hey, you have a stone, it's probably going to pass, but we wonder, are you developing an infection? Here's what to look for. Come back immediately if they develop.
We've talked about the fact that macrobid nitrofurantoin is a urinary antiseptic, doesn't penetrate the renal parenchyma. So, I mean, antibiotics for infected stones are one thing, but I mean, if you're going to do it and you think it's maybe not completely obstructing and then follow up with urology tomorrow, at least give an antibiotic you think might be helpful against that potential infection.
Absolutely. And document to the best of your ability the conversation with the consultant. It doesn't have to be a transcript, and it shouldn't be. But what were the issues? What did you tell them? And what were their responses? And make sure the most important question you're asking them is in your documentation, and so is their response.
This last part is tough, and I get it. I know how they answered those questions. I think it's instructive to all of us to see how that will play out later as far as interaction with the consultant. We're going to find more interaction with consultants in the next and final case. But in the end, it is our ultimate responsibility. And, you know, if you feel like you like company and want to sit up on the chair at the defense table with somebody else and you really have a good time hanging out with urologists or cardiologists, great, bring them along for the ride. But in the end, there's no way they're only naming them. They will name us also. So the ultimate responsibility is us. We saw the patient. If there is rogue information given to us, it's our responsibility to know that. It's great to get that advice, reflecting that on the chart, but in the end, this is our patient.